All right. Good afternoon, everybody. Wanted to give a couple seconds for people to join us today. Um, Welcome to today's webinar, Consideration of the One Big Beautiful Bill Act on Public Health. I'm Kate Smith. I'm Executive Director of the Delaware Academy of Medicine and the Delaware Public Health Association. I'm joined today by Christine Ganella, the Executive Director of the Pennsylvania Public Health Association and Managing Director of Strategy Development with Public Health Management Corporation. Today's webinar is hosted by the Mid-Atlantic Public Health Partnership, a collaboration of public health associations representing the Mid-Atlantic states. Today's webinar is being recorded and will be available in the next day or two on Train PA's learning management system. Additionally, a link to the recording will be sent to all registrants. All participants will be muted throughout the presentation. We do encourage our participants to submit questions during the presentation. To do so, please use the Q&A tab on your Zoom control panel, and it will be relayed to the presenters and answered at the end of the webinar. Please use the chat feature to introduce yourself and to share any tech issues that you might be having. We will be monitoring both. To enable captioning, please click on the closed caption button along the bottom of your Zoom window. You will see the option to enable live transcripts. And a post-webinar survey will pop up at the end of the webinar. Please take a few minutes to complete this survey to evaluate this webinar, as your feedback is critical to the ongoing development of new webinar topics. So, without further ado, I would like to take the opportunity to introduce our panel of speakers today. First, we have Richard Van Buren. Rick Van Buren is a policy professional with over a decade of experience in federal healthcare, advising on national healthcare access, coverage, and reimbursement policies. He has served in senior roles on the Energy and Commerce Committee at MACPAC and at CMS, with deep expertise in Medicaid, CHIP, and community health programs. Rick holds a JD from Georgetown University Law Center and a BA from the University of Pittsburgh. Greg Geer is a health policy expert with over 20 years of experience in Medicare, the Affordable Care Act, and health system reforms. He has held senior policy roles at Health Management Associates, the Better Medicare Alliance, and AHIP, shaping key healthcare policies. Greg holds a Master of Public Policy from Georgetown University and serves on the Cancer Support Community's Cancer Policy Institute Advisory Board. And finally, we have Dr. Krishna Upadhyay. Dr. Upadhyay is the Chief Medical Officer for the Delaware Division of Medicaid and Medical Assistance and a passionate advocate for the health of people and communities. She earned her medical degree with honors from the University of Illinois at Chicago College of Medicine and completed her residency in general pediatrics and fellowship at adolescent medicine at the Johns Hopkins School of Medicine. Dr. Upadhyay also holds a Master of Public Health degree with an emphasis on maternal and child health from Boston University and a Bachelor of Arts from Duke University. Without further ado, Rick.
Thank you, Kate. Thanks for that introduction, and thank you for having us here today to talk about this. Really happy to dive into talking through the public health implications for the One Big Beautiful Bill Act, or the OBBBA, or HR1, or OB3. I don't think folks have settled on the branding for it yet, but anytime people are talking about that, I think just to table set, it's all the same bill. So do we want to advance to the next slide? And the next slide. And okay, so just to table set and to take us back to how HR1 got passed. This was a bill passed through reconciliation, which is essentially a procedural process that allows the Senate to bypass the filibuster to pass legislation, and is typically used whenever one party is in control of the House, the Senate, and the presidency. So we saw it twice under the Biden administration. We saw it once under Trump 1, and now this is the first time it's been used under Trump 2. And just to kind of level set, we're all, or I think most of us are health policy folks, so we view this bill through a health policy lens, and it does make profound changes to health healthcare and health programs. If you talk to your average Republican member of Congress, they view this largely and primarily as a tax bill that was designed to pass to extend the what I'll call the Trump tax cuts from his first term, and the health implications were sort of a secondary concern for most of them. Um, I will be focusing primarily on the Rural Health Transformation Program, which was added relatively late in the process. And just to take us back, um, there was a deadline set by leadership, by Republican leadership and the president to get the bill to his desk by July 4th. And as the clock ticked closer to that, there were a number of Republican holdouts in both the House and the Senate. There were very thin margins to pass this. No Democrats were going to vote for it. So one of the emerging concerns for these members was the impact that the bill's Medicaid cuts would have on rural communities. In particular, Senators Murkowski from Alaska and Senator Collins from Maine both expressed concern about rural healthcare providers. So in the um, hours leading up to the final vote, the Rural Health Transformation Program was sort of finalized. And and I think, I just provide that background because I think it's important to know that this particular program was really did not have the sort of same level of consideration or drafting behind it as some of the other provisions in the bill. So there's going to be a lot of, I think folks are still sort of unpacking and have a lot of questions maybe about how it will be operationalized, what it will look like. So with that in mind, we can go ahead and jump forward to the next slide. We can go to the next slide after this. Um, we can skip to the next slide after this. Okay, so thank you. So the Rural Health Transformation Program, very high level. This is a $50 billion program authorized for 5 years that will be provided as grants to the 50 states. It's only available to the 50 states, no District of Columbia, no territories. Intended essentially to sort of shore up rural healthcare providers. And the structure of it is that by December 31st, 2025, so 4 months from now, states must submit an application for the program in a form and manner as determined by the CMS administrator. Um, the law also requires that the administrator approve or deny all applications by that same date. That's a little unusual that like applications could be due on the 31st and also have to be approved or denied by the same date. So I think what we expect is that the administrator, in this case, Dr. Oz, will establish a deadline for those applications prior to December 31st, 2025. And just as an aside, it's my understanding that the folks at CMS are working as fast as they can to sort of get the to get this program off the ground and to get the sort of structure established for those applications. We can go ahead and advance to the next slide. Um, so there are a number of factors that the applications have to include. I won't go through all 10 of them, but they're essentially describing in detail how the state will use the funds to strengthen its rural healthcare providers and delivery system and et cetera. Uh, the law states that 50%, so it's a $50 billion program over 5 years, which is $10 billion a year. 50% of that $10 billion has to be distributed equally or allotted equally among all the states with an approved application. So if we assume every state submits an application, which I think is safe since it's basically free money for the states, and if we also assume that every state's application is approved, which, TBD if that's true or not, But that means that every state would get $100 million, million with an M, um, annually for the next 5 years for use. The other 50% is to be allotted by the CMS administrator, and he has fairly broad discretion in how to allot those funds. The law states that at least a quarter of the states with an approved application, so if all 50 states submit an application, that would be 13 states. The second 50% has to be distributed to at least 13 states. And then he has broad discretion. It said the law says he has to consider the percentage of population in a state located in a rural tract, the proportion of rural health facilities um, in a state, and um, and the situation of hospitals in the state, typically like looking at whether they serve a disproportionate amount of low income providers. Rural healthcare facility is fairly broadly defined. It's generally going to be acute care hospitals in rural areas. Notably, it also includes FQHCs, community mental health centers, um, certified community behavioral health centers, 330 grantees under the Public Health Service Act. It doesn't appear that those have to be in a rural area. And as we all know, those can be located in urban areas. There's another section here then that establishes terms and conditions that each state has to meet, that seems to be separate and apart from the application that they have to submit by the 31st. And it's unclear how these terms and conditions intersect with the application requirements. Um, but the app, oh, sorry, we can go ahead, we can advance forward. Um, but basically, the terms and conditions state sort of 10 allowable uses of funds. The states have to select at least three of them and explain how they're going to use the funds to enhance um, those three factors. The states have to submit annual reports on the use of the funds. States are limited to using 10% of the funds for administrative purposes. And there's a provision that states that the secretary, sorry, not the secretary, the CMS administrator uh, can actually rescind, reduce, or reclaim funds if he determines that they are being used in a way that doesn't comply with the application. Oh, and I should have said states they can use the funds for the fiscal year following the fiscal year that the funds are dispersed. So they have basically states have 1 year to use these funds. It is use or to lose it. If they don't use them, they're reclaimed and redistributed among the other states. Um, so I think there's a lot of interest in this fund at a high level. There's a lot of questions about it. We have not yet seen guidance from CMS on how states can apply, how states can use these funds beyond what's in the statute. But I think folks are eagerly anticipating it. Beyond the, sorry, oh, and we're on the right slide. Beyond the Rural Health Transformation Program, we are keeping, obviously, there is a lot of focus on the annual appropriations process, which happens annually. And there are a number of programs that we all care about that are set to expire at the end of this fiscal year. I'm not going to name them all, but I think, the community health center averting the Medicaid dish cuts, um, those are telehealth authorities, several other sort of technical Medicare authorities. Um, those were not extended through reconciliation. Those are going to be subject to annual appropriations that would be on a bipartisan basis. And right now, I think there's just a big question mark about whether Congress is able to extend those before, extend federal funding before September 30th, whether we enter a shutdown, um, whether we see a continuing resolution for a short term to give Congress more time to work, like let's say through December, whether it's a long-term continuing resolution for a fiscal year. Those are all question marks. And, based on conversations with folks, I don't think staff on the Hill or members are totally clear on the answers to those. That was a lot of content. I see I'm at time, so with that, I will throw it back. Uh, I will throw it back to Kate.
All right. Thank you very much. Appreciate that. Without further ado, I think we're going to go over to Greg.
Thanks, Kate. Good to be here. Appreciate the opportunity to present on today's webinar and be part of this panel discussing the implications of the recently enacted final budget reconciliation bill, particularly its impacts on public health. So just high level, wanted to touch on sort of three things, provide sort of a high level overview of the final budget reconciliation legislation, discuss those policy implications, particularly the impact on public health, and sort of next steps in the process. Obviously, this is landmark legislation that's passed, and now we've moved to the next phase, which is sort of the implementation phase. And then wanted to drill down on some of the key Medicaid funding reductions that will impact public health. So overview, I think Rick touched on a lot of this earlier. I would just say that this sort of budget reconciliation process, which you correctly noted, is sort of a very process-driven way for Congress to enact their priorities and be able to sort of skirt the normal rules, the Senate filibuster being most prominent there. But this went through several iterations over the summer, and there were sort of notable policy changes as this sort of wended its way through the process. Let's go to the next slide. So there's sort of three major buckets in the healthcare provisions of the budget reconciliation package. There's Medicaid, of course, which we'll be talking about in much more detail later on in the webinar. There's the ACA marketplaces, and there's some sort of notable changes to the Medicare program. Let's go to the next slide. This is really going about the impact, but one thing I want to underscore is sort of as this legislation moved through the process, House passage by Memorial Day, the Senate passed version about a month later, culminating in its package, that these provisions sort of changed over time. And actually, the Senate passed version actually included, steeper Medicaid funding reductions than the House passed version. That was ultimately agreed to, passed by the House and signed into law. But overall, this is sort of looking at the Congressional Budget Office, which is the nonpartisan, scorekeeper of major legislation in Congress for major bills. They do cost estimates and impact analysis about an impact on federal revenues and broader sort of economic-wide impacts overall. And so overall, this legislation, when you combine sort of the Medicaid funding reductions with sort of the changes in ACA, would reduce healthcare spending by over $1 trillion over the next 10 years. The vast majority of that is from Medicaid funding reductions, about $990 billion in the final package. When you consider sort of interaction effects, still well north of 900 billion, which is, obviously unprecedented. I know that word gets used a lot or often and maybe overstated, but in this case, it's certainly apt. There's never been legislation that contemplated, spending reductions of this magnitude. It's about 14 to 15% of total Medicaid spending over the 10-year time frame. And so obviously that's going to have, very significant implications for coverage, for state budgets, for states' ability to manage their Medicaid programs, and far-reaching effects. Overall, despite sort of the very large spending reductions, the CBO found that this legislation would actually increase the deficit by 3.4 trillion over the next decade. That is because the cost of extending the tax cuts, which is the sort of the primary purpose of this legislation, plus new tax incentives, despite these sort of unprecedented healthcare funding reductions, this legislation will still increase the deficit over the 10-year period. And then final point here is about what the coverage loss is. So this information has been updated. Actually, CBO didn't do a formal cost estimate until after the legislation passed, which really speaks to sort of the unprecedented nature of how this legislation moved through the process so quickly. But overall, they estimate that the number of uninsured will increase by 10 million individuals over the 10-year period. Mostly this is due to sort of the Medicaid funding reductions, but also the various sort of changes to the ACA exchange marketplaces that'll make it sort of more difficult for people to obtain and retain coverage in the state and federal marketplaces. Next slide. Before I get into sort of the takeaways here, I wanted to touch on sort of the public health implications of this legislation. I put them in sort of 4 categories. One is, as I was talking in the earlier slide, is sort of these anticipated losses of coverage. Most of that is going to be driven, according to the Congressional Budget Office and independent experts, driven by the new work and community engagement requirement, which is new. It's both most of the savings, most of the Medicaid savings in the legislation, and is also responsible for most of the coverage losses. Experts that have looked at this said that these sort of work requirements, based on what states have done previously in the first Trump administration, and sort of the experience with these, is that due to sort of the paperwork requirements of documenting work, people otherwise eligible are going to lose coverage. So that's a huge public health implication. How do states manage this? How do systems get set up to address this issue? But that's sort of number one. Number two is future challenges for how states finance their non-federal share of Medicaid. And so one way to think about these sort of interconnected reforms to Medicaid, one is sort of a series of provisions that are really intended to make it more difficult for people to gain access to Medicaid coverage and retain that coverage. Obviously, the work requirement is one example. More frequent eligibility checks is another example. So that's sort of like one bucket of reforms. The other bucket is sort of saving federal funding money by shifting costs to states, including new restrictions on how states finance their non-federal share. And so those provisions are very significant. Medicaid expansion states are going to face larger federal spending reductions and enrollment losses than non-expansion states. And so something that will have implications for states, state budgets, state Medicaid programs, and the ability to sort of maintain those initiatives. Third is sort of new limitations on how states can improve quality of care and access via new restrictions on state-directed payments. So these were ways that states could increase access to care and improve sort of provider payment rates by paying greater than the Medicaid rate, sometimes in some cases greater than the Medicare rate. An important way for states to sort of innovate on value-based payment as well. And so there's new restrictions there, which will have public health implications. And then finally, the big one is sort of the anticipated increase in uncompensated care costs as a result of this legislation, and particularly the coverage losses. So here, we're looking at, a significant increase in uncompensated care costs for hospitals and health systems, particularly community health centers, which, as everyone knows, really provides cost-effective primary care to over 16 million Medicaid beneficiaries. These sort of spending reductions of this magnitude are really going to strain hospital finances, especially in rural and underserved areas. Of course, Rick mentioned the Rural Transformation Fund, that is expected to sort of provide some level of relief, but, significant financial headwinds here. First takeaway, just to pivot away and get a little bit bigger picture, is that these eligibility enrollment changes are going to impact access. They're going to create new administrative requirements for states and state Medicaid programs. I mentioned the federal work requirements and Medicaid, complex procedures to be implemented very soon, up and running by December 31st of next year. And so quite a lot of work to be done before that. And then I'd also mention here that the legislation also placed moratoriums on sort of earlier Biden era rules that were really focused on continuous coverage and access. And so that's sort of a piece here to keep in mind when you're thinking about how these provisions interact with each other and sort of those challenges. Takeaway number 2, next slide, is really focused on these sort of budgetary and financial pressures that are going to be impacting states, state Medicaid programs, local communities, counties, due to sort of these federal funding reductions. This will drive difficult decisions by states on how to sustain their programs, and how to sort of care for vulnerable populations amid an environment of sort of reduced federal support. And so, that's certainly the other key takeaway here. Next slide. So what's next? Here, this is obviously, this passage of this legislation is an important milestone, but now we turn into the next phase, which is implementation. As Rick mentioned, this legislation's wide ranging and complex. There's multiple timelines and phase-in periods. So, and this is just the start of the next phase of the process, where federal regulations are going to be written. States are going to be doing their own sort of state impact analysis of what these implications are for their particular programs. As I mentioned earlier, the impact of these cuts are not going to be sort of uniform across states. States are going to be impacted disproportionately, depending on whether or not they expanded Medicaid, how they currently finance their non-federal share, including how their sort of provider taxes are structured, and then make changes accordingly. And then, in addition to the federal regulatory process, which is kicking into gears now and over the next several months, and really years ahead, will be sort of state level policy making. So in face of this sort of federal legislation, given the significant cost shift to states are going to have to make decisions around current level of provider payments, benefit levels, eligibility changes, potentially, and other ways to sort of manage this far sweeping legislation. Next slide. And this slide just talks about sort of, which I already touched on, is sort of how different stakeholders can engage in the process. There's going to be a very intensive federal regulatory process, underway. Some of it is sort of written in the statute, particularly, the work requirement that there has to be an interim final rule by June of next year there. But opportunities for stakeholders to sort of engage in sort of the notice and comment process, the guidances that'll be coming out as these sort of provisions are implemented over the next several years. Important to note here too is that a lot of these provisions are sort of backloaded. Some go into effect immediately, but the major sort of Medicaid funding reductions are sort of backloaded. over the next several years. So something to sort of keep in mind as this sort of plays out, for states, for health plans, for healthcare providers, for community benefit organizations that work in this space, and particularly those to serve, this vulnerable population, how to sort of, manage these risks, but also a way to look for opportunities as well. Next slide. So I'm gonna touch on some of these key provisions. As I mentioned earlier, they fall into sort of two buckets. One is sort of requirements, new federal requirements that are really looking to sort of shrink Medicaid enrollment by requiring more frequent eligibility checks, by requiring new reporting requirements, most notably be the work requirement. So only applies to the Medicaid expansion population. There are a number of sort of federal exceptions to the work requirement. Some are optional, some are mandatory. States will have some flexibility in implementing this program. For example, states can require kind of more frequent eligibility checks. There is expected to be sort of federal rulemaking, as I mentioned earlier, by June 1st of next year. But obviously, this is a huge operational lift for states to implement something like this in this compressed time period. How do you rely on sort of existing data sources to the extent possible, minimize reporting requirements for beneficiaries? We know that this is a population that requires, significant healthcare needs, but also how do you sort of address these issues that create friction and would otherwise cause otherwise eligible people to sort of lose coverage. So let's go to the next slide. I would note on the Medicaid work requirement, that is the single largest source of funding, federal funding savings from the package. The second category is sort of on the whole bucket of provider taxes. So there's a number of reforms here, interconnected reforms. One is sort of this moratorium on new or increased provider taxes, which basically freezes them at their current level. Like the other provisions, it's sort of a phase in. When you combine this sort of provision with the others, this is going to create, significant issues in a number of states about how they sort of finance their non-federal share and how they sustain their programs. Next slide. And this is the related provision about the provider taxes and particularly lowering this the uniform tax requirement. This is going to create, again, disproportionate impact on states depending on how sort of they currently finance their non-federal share through provider taxes. It will likely require new strategies to address and identify additional state funds. It's going to create pressure on providers due to uncompensated care. It's going to be a real challenge that is not going to be felt sort of the same across all states. So just important to keep that in mind. Next slide. This is the issue I was mentioning earlier around state-directed payments. This is also one of those provisions that sort of is disproportionately impacts states that expanded Medicaid. This was an important innovation for states as far as, strengthening their Medicaid programs, ensuring patient access, ensuring sort of the viability of safety net providers. But now this sort of policy has been constrained due to the passage of the final budget reconciliation legislation. And so obviously it's going to impact state budgets. Like the other provisions, it's going to require new strategies to sort of identify additional funds to make up this shortfall put pressure on states overall as far as effectively managing their programs in the face of these significant headwinds. Next slide. Oh, this is the eligibility determinations, which I think I covered earlier. Kind of two things here is sort of This will be a new requirement for states to conduct more frequent eligibility redeterminations instead of once a year, every 6 months. Experts that have looked at this that's going to cause people to drop off Medicaid coverage, not because they're not eligible, but because of the new requirement. And as I mentioned earlier, this is kind of tied very closely with these moratorium on rules from the previous administration that really looked to sort of simplify the enrollment process, promote continuous coverage. And this policy, coupled with sort of the moratorium on those previous regulations, are going to lead to significant loss of coverage as well. And so from a state perspective, this is going to require both new administrative and operational complexity to do this, and funding, and also need to think about, in light of these new federal requirements, how do you sort of minimize avoidable coverage losses? So that about covers it for me. Just wanted to sort of recap on the things. Obviously this is significant legislation that's now moved into an important new phase, which is the implementation phase. And so I think I touched on a lot of the challenges. There are also opportunities for states and stakeholders and public health associations to engage in the process. There's the federal regulatory process. There's opportunity to sort of size this issue at the state level. Impact analysis, whether it's Congressional Budget Office or other sort of independent think tanks. A lot of these impacts are going to be very different depending on the state Medicaid program. And so really having an appreciation of the size of this and having that kind of state level analysis will be important. And then opportunity to kind of engage at state level policymaking as this continues through the process. So with that, I think I'm going to pause there and looking forward to the discussion later. And I'll turn it back to Kate for the next panelist. Thanks so much. I really appreciate it.
Thank you, Greg. We appreciate you being here. All right, Dr. Upadhyay, you ready to bring it home?
Thank you. I am. So thanks, Zaya. Thanks for having me. And I think I'm going to share from the Medicaid perspective at the state level. But as I do that, I wanted to just kind of keep in mind, I put this image here because, I think any of us who work in public health or healthcare understand that, all of these things are connected. So even though there's a lot of emphasis, or I'm going to talk from the Medicaid perspective, we can't make impacts in Medicaid that don't impact the rest of the healthcare and public health ecosystem. And so that's something I think, that we are just going to be experiencing as we go through time on the implementation. On the next slide, I wanted to also just start with the mission. So I think as we think about how this is going to impact our state and our beneficiaries in Delaware, we do want to keep in mind what our mission is, just really improve health outcomes in the state and ensure that people are really getting the quality health care that we need. And obviously, we're going to be facing a number of challenges to that as we think about how we comply with the new rules. But nothing about the new rules changes what we are aiming to do in our program. And so that's something that I think we always want to keep in mind. I think on the Medicaid side, in addition to us wanting to serve beneficiaries, we also know as a state that we can't serve the beneficiaries without providers who want to participate in our program. And I think that a lot of the provisions in the bill that have been laid out by the prior panelists really do have a lot of significant impacts, again, on the overall healthcare ecosystem, which impacts our providers, which then may impact their ability to serve our beneficiaries. So again, a lot of overlapping effects. Just to give some context, as of right now, as of the most recent data that CMS has released, there are more than 70 million people enrolled in Medicaid nationwide. That has come down a little bit over time because there were some expansions of coverage and some pauses on redeterminations during the public health emergency. And so as that has been rolled back, there have been some declines in coverage, but still this is a massive program that is serving many, many millions of people across the country. And if we can go to the next slide, in Delaware specifically, Medicaid is serving around 250,000. It's around a quarter of our state that is enrolled in Medicaid. Again, there were some declines with changes after the public health emergency, but it's still about a quarter of the state, and notably about just under 50% of births in the state are covered by Medicaid in Delaware, and that is pretty similar across the country. So a very important program for serving people. If we can go to the next slide, I think one of the things that I always like to talk about is that just the sort of the fundamentals of how the Medicaid program is structured. I think the other panelists alluded to the fact that there'll be different impacts on the current legislation depending on the state. And that really has to do with the way this program is structured. And I think it's important for people to keep in mind that this really is a federal and state partnership. The federal government does set certain core requirements on eligibility and benefits, and obviously those have been impacted by this legislation. But then states do have flexibility with authorization from the federal government to administer the program, to define other benefits and things of that nature. And so, but that does require states to, contribute funding to the program, and particularly to some of the extra or added benefits that go above the core. And so those are the kinds of things that will vary by state, and that states are going to have to keep in mind as they figure out how to implement the current requirements. So specifically on the next slide, as a state Medicaid program, we kind of have four key aspects of the program that we need to contribute to the partnership. That is, again, establishing eligibility standards within the state, determining the type, amount, duration, and scope of services, setting capitation rates for our managed care for those states that participate in managed care, which ours does, and then to administer the program. And really, I think this current legislation has it does have some impacts. I think there are some regulatory changes related to the capitation rates, but for the most part, there's going to be a lot of changes on those top two parts of the work that we do as a state. And if we can go to the next slide to focus a little bit on the financial eligibility, I think, again, thinking about how this is going to impact a state, this chart it aims to show the different sort of buckets of populations of people that are potentially eligible to participate in Medicaid program. And the federal minimal requirements are in that first column after the eligibility group. And states do have the ability to go above and beyond that. So to expand the definition of who might be covered. And in the case of Delaware, on the far right column, you can see sort of how Delaware has decided to expand eligibility in these different groups, and in many cases has gone above and beyond to cover more people in the program than would be like the baseline requirement. But again, those choices do come with a cost, and each population and each service is covered with, we receive as a state a certain proportion of that funding from the federal government, and then the state is required to fund the state share of those benefits. And so anything that takes more money because the state may be pulling back requires more money on the state, and states then may have to think about whether or not they can continue some of those added groups for eligibility and services in light of budget cuts. So those are some of the things that we're having to consider at the state level. If we can go to the next slide, I also want to just highlight again, every state has a set of mandatory benefits that the federal government requires them to cover. And if you look at the list, you can see there's a lot of things that I think most of us would say are really important to someone's healthcare coverage that are not included in here. But this is the mandatory set of services that states are required to cover, that are listed in what every state has, which is a state plan. But if you go to the next slide, what we know is that we can get approval as a state to cover additional benefits. So even things like prescription drugs considered to be sort of above and beyond the minimal baseline that would be required for a state to do. So many states, including ours, are covering services, like really critical services for people across these different domains. And these, again, every state has to have approval through different types of waivers in order to cover these. And then again, there will be a federal portion of that financing and then a state portion. So I'd just like to highlight again, what is considered the baseline and what is really above and beyond, just to keep in context when funding may start to be harder to come by in certain areas, the list of potential things that states have to consider, how to continue supporting them. To go to the next slide, some of the waivers that people might be familiar with that are the most common ways that states will ask for flexibility from CMS are 1915 waivers and 1115 waivers. We understand, and again, in Delaware, most of our services are delivered through an 1115 waiver, although we do have other waivers that cover certain populations. And so again, CMS has given us authority to cover services that are, above and beyond the minimum and to finance them in certain ways. And these waivers are approved for a certain period of time. So our current 1115 waiver in Delaware is through the end of 2028. And then, after that, we have to ask for additional authorization from CMS to make changes. So I just wanted to sort of give those kind of baselines of just to give some context in terms of the kinds of things that are potentially, needing to be considered at the state level as we think about the new requirements. To go to the next slide, sorry, if we can go to the next one after this. I do want to highlight that there is a phased-in approach, and if folks aren't familiar with the National Association of Medicaid Directors, they have some really good resources for people who are trying to understand the timeline. There was a provision related to restrictions on certain family planning providers that was set to take place as soon as the bill was enacted, and that's currently being challenged in court. But for the most part, the things that states are going to have to implement are going to take place between now and 2028. And as was referenced earlier, at the state level, we are having to think about how will we start to implement these things, while also knowing that we actually are going to need specific sort of guidance, regulatory guidance from the federal government in order to know, more specifically what are the requirements for any of these changes that have happened. And that's something that we're, obviously we're still waiting on. And I can say from the state Medicaid side, any one of these changes is a very significant thing to operationalize. And so, when the legislation requires CMS, as an example, to put out regulatory guidance on the work requirements, which we heard a lot about I think it's, they're required to put out the guidance by June of 2026 for something that's supposed to be implemented by essentially January 1st, 2027. That's an extremely tight timeline for states, and something that's, there's a lot that has to go into thinking about how to operationalize any one of these things. So certainly a challenge. If we can go to the next slide. I think we heard about these earlier, and I think so I'm kind of reiterating from the state standpoint, what are some of the biggest challenges? I think the work requirements and the 6-month eligibility determinations, these are things that will require states to have systems in place. And again, our goal is really to minimize the churn and the burden on people who are eligible. But we know that anytime we have to add additional steps to eligibility determinations, there's a risk of people losing coverage, even if they remain eligible. And so that's something that is definitely a challenge. I think something that hasn't been mentioned as much, but I think the restrictions on coverage for some legal immigrant groups, currently legal immigrant statuses, that is something that is also going to have a big impact on who's eligible for the program. And then when those groups are no longer eligible, again, the trickle down effects on those folks not having an ability to pay for care that they are going to need is going to have a big impact, I think, on providers, and that will then impact the rest of the system. And then again, the things that were mentioned about limiting on the provider taxes and the state directed payments, again, just it will certainly impact the states, where states can look for the money that they need to fund their share, and also their ability to really attract and retain providers in the system, which is really critically important. On the other hand, if we can go to the next slide, as was mentioned, there are some potential opportunities. I think we're still waiting to understand, how, again, what are the opportunities here? How will these things be rolled out? But we're certainly going to be looking for anything that we can do to take advantage of these new opportunities that are in the legislation to try to, address some potential gaps that may be coming through other parts, or to expand opportunities for people to get coverage where that is possible. On the next slide, I think the big pictures takeaways is that there is going to be increased oversight on eligibility, and we're going to have to really work to build the infrastructure to implement those new requirements. Additionally, I know in the sessions that I've been in with folks from CMS, there's a lot of emphasis on making sure that they're focused on fraud, waste, and abuse. So making sure we already have a lot of systems in place to ensure that payments are going only for covered services and to eligible providers, but we're going to have to even do more to make sure that that is the case under the new rules. And then certainly, as even though a lot of the changes are focused on, for example, the Medicaid expansion population, we know that anytime we are taking money out of the system, it has the potential to affect the other sort of what CMS might term to be the sort of core populations that the program serves. And so those are things that we're going to be really looking to minimize, but we'll have to be aware of. I know I'm almost at time, but the last thing I want to just highlight again is, if we can go to the next slide, that really our goals as a state during this implementation phase is really to minimize the burden to the extent we can on our members and any and providers. We're going to continue to look for any creative opportunities we have to advance our program. And we have a lot of stakeholders involved in the program, and we have to just acknowledge that there's a lot we still don't know, and we are going to be really working to work with our stakeholders and really just navigate the uncertainty together as we move forward. So I think the last thing I put was, again, just the ripple effects, and we know this is going to impact a lot of things. And then I think I did have one extra slide, which again, just to circle back to the mission, and just to say, if we can go to the last slide, which is that, we know that our mission hasn't changed. We know that Medicaid serves a number of people and is a really, really critical program. And so we're going to be working as hard as we can to keep all those things going in light of the new changes.
Thank you so much. There was so much information that was packed into our hour together, and just really grateful for all of our panelists who presented today. The slides will be available as well as the recording. As Kate mentioned in the beginning of the webinar, the slides and the recording will be posted on Train PA's learning management system. Again, I want to thank everyone for your participation and to our speakers. I just want to make a plug. If you will be participating at the APHA conference in DC, November 2nd through the 5th. November 2nd, the Mid-Atlantic Public Health Partnership will be hosting a breakfast. So please join us there. We would love to see you. The QR code here, you can scan that to register. And if you are not on our newsletter, Hayden is going to pop in the chat the opportunity to sign up for our newsletter, follow PPHA on any of the social media opportunities here, but we'll make sure that you get information. And if you're interested in getting access to our newsletter, please sign up. We would love to share information with you. So again, I want to thank everyone. I want to be mindful of time. It is 12:58, and I know everyone has tight schedules. So I want to, again, thank our panelists for your presentation today, as well as all the participants of the webinar, all of our attendees. So thank you, everyone. Wonderful to see everyone. Have a wonderful rest of your day and a wonderful rest of your August as you close out your summer. Take care and join us again for another webinar.